Well, good evening, everyone, and I assume you can see my screen. I have no financial interest to disclose here. So let's talk about my best pearls. And, this is what we're trying to avoid with pseudoexfoliation, this late bag IOL dislocation. So we're not only trying to preserve the capsule, but avoid this complication. And we have these challenges. The pupil's small. It's hard to control the rexus. It can be hard to rotate the nucleus. The zonules are very likely to have a dialysis or to tear, and the posterior capsule is not taut. So these are my six pearls. Make the rexus smaller if you need to. You can always enlarge it. Use capsule retractors rather than iris hooks. Continually re-inflate the bag with dispersive viscoelastic. Consider bimanual INA. Delay the CTR until after removing the cortex, and consider putting a three-piece IOL in the sulcus. So my goal today is to show you some of my best teaching videos on these points. Look at the movement of the peripheral anterior capsule. This is as though it's elastic. I call it pseudoelasticity because it means the zonules to your left are weak. So this is why it's hard to tear the rexus when I'm using the Brian Little capsule tear out rescue maneuver to try to control it here. So as you're making your tear, if you see the peripheral anterior capsule moving, beware. That means the zonules are weak. Now, how do you avoid capsular phimosis? Phimosis like this means that you've got diffuse zonulopathy. So if I'm not putting in a CTR, because here with pseudoexfoliation, not always do the zonules seem weak, I don't want to leave the rexus small, and even though this rexus isn't that small, I'm going to secondarily enlarge it. You make an oblique cut and re-tear it. It's rather easy because you have a good view. You know exactly how large to make it. And if there's an errant tear, it doesn't matter at this point. Think about the rexus as though it's a sphincter. In fact, every rexus would end up with phimosis were it not for the counter pull from the zonules. And so that is why with weak zonules, we want to reduce that sphincter-like force by enlarging it. This is, going right out to the edge of the optic. I'm not so much worried about PCO. And when you look at these eyes months and years later, they're absolutely quiet. Now, not everyone's comfortable with this. Another option is to make little radial partial cuts in the CCC edge. You don't have to go way out peripherally. You're just trying to prevent contracture, which in turn reduces or strips more zonules. Now, here's a zonule dialysis nasal. You see where the arrows are. And so I'm thinking I'm going to put a CTR in because it looks like 4 clock hours. And now you'll see that it's really more like a 8 clock hour zonule dialysis. There's no zonules over here on the right. And so that's why I got the dialysis, because the anterior capsule isn't fixated. Now look at the problem. When I aspirate over on the left, the entire capsular bag is moving, so the CTR isn't really helping. In fact, it's transmitting my cortical stripping forces to all 360 degrees of the zonules. So the CTR might help when you have 3 clock hours of zonulopathy. It's a disadvantage when you have 9 clock hours of zonulopathy. So it is making matters worse, and I would have been better off not putting in. Instead, what I should have done is put in capsule retractors. This is the microsurgical technology version 2 that I helped design. And what these do is they support the bag in an AP direction. They keep the peripheral fornices from being aspirated by the phaco tip, but they don't trap the cortex later on. They're also going to fixate the bag to the sclera, making it easier to rotate the nucleus because now the bag has the proper counterfixation. So think of them as artificial zonules. So you see, I put them in and then I do my rotation. And this is something that I think makes this is absolutely essential when you have severe zonulopathy. You can use iris retractors, but they're going to put a lot of tension on the CCC edge. The goal is not to stretch the CCC edge too much, rather just to support the capsule. And then Phaco chop is, of course, a great technique to further avoid stress on the capsular bag with our Phaco maneuvers. This, of course, is a softer nucleus, which helps. Now, look at the posterior capsule. I've got the last piece, and I'm guarding it, my Phaco tip, with the chopper, but it's still prolapsed forward. And that's because the zonules are weak, and so the posterior capsule isn't taut, and it likes to fly up toward the Phaco tip. So there you see the opening from the rent. So what I should have done is, in a case with pseudoexfoliation, when you have that last piece, stop and use a dispersive viscoelastic to fill the capsular bag. And you're not just pushing the bag back, you're actually filling it. So you're putting the posterior capsule on stretch, and the dispersive doesn't come out. I like using bimanual INA. Now look at how the posterior capsule in this same case wants to come with the cortex right up to the port. Bimanual INA helps me keep the port away from the posterior capsule, but the problem is I don't have tight zonules to keep the posterior capsule on stretch, and so it, like a sail that doesn't have enough wind, is luffing. It wants to come forward. So look at how much better I can do when I fill the posterior capsule, fill the capsular bag with the dispersive viscoelastic. It holds it back, so it's the viscoelastic that's putting the capsule on stretch in the absence of good zonules, and that makes this procedure much safer. Now, sometimes you do everything right. You put the lens in the bag, and look at what I'm seeing. I've got pseudophacodenesis with a three-piece with a CTR in the capsular bag. So the question is, what should I do now? I could suture this maybe to the sclera. But since I'm in surgery, I decide I'm going to take this three-piece and put it in the sulcus. To do that, I have to first move it into the anterior chamber. Why? Because the posterior angulation means that the haptics are angled anteriorly, the optic vaults posteriorly. So the only way to be sure I have both haptics in the sulcus is to bring them forward, and then one at a time go right under the iris edge with each haptic, and then I'm in the sulcus. So I've simply moved this from the bag to the sulcus. You see the bleb is on the right with this pseudoexfoliation case. So I now shake the eye, and the lens doesn't move. So this is a very important teaching case because it's the same eye with the same lens. The only difference is you've seen it in the bag and in the sulcus. And the explanation has to be that in the sulcus, I get additional 2-point fixation during eye movements, as though I had scleral fixation rather than only zonular fixation. And so I now do this all the time. I capture the optic to prevent rexus contraction and to help with the centration. It keeps the haptic from rotating if I have a zonular dialysis, and I don't have to adjust the power. Here, look at the CTR bend. And when you see the CTR bend like that, you have to stop because it's not advancing. And in this traumatic zonular dialysis, it's probably because I don't have enough viscoelastic and there's some folds in the capsule. I refill. You can even do this maneuver where I kind of pre-bend it with another instrument to pass this danger zone. But when you feel too much tension with the CTR, you have to stop. It's not something you'll see in the video, but you will see this bowing of the CTR like an archery bow with the tension. Now I'm going to put in a three-piece IOL here, and because of that last case, I'm going to put it in the sulcus because, again, I know I've got zonulopathy, and the only difference is I'm going to try to aim the haptics away from the zonular dialysis nasally. Before I capture the optic, it's important to go in, just remove a little of the viscoelastic because it's all going to be trapped in the bag, because when you buttonhole the optic, as I'm doing here, it can't escape. And you see how this keeps the IOL from rotating and the haptics from going through that zonular dialysis. My last video is with this ultrabrunescent lens, and I can see right away I've got zonulopathy, even though I'm planning to phaco. And now when I do my rhexis, there's severe zonulopathy. So I decide this is better off if I convert to an extra cap. So I'm going to use my needle and convert to a can opener. I'm going to abandon my temporal clear corneal incision. I'm going to go superiorly because that clear corneal incision is self-sealing. And I want a fresh area to make my extra cap incision. Many of you can do manual small incisions, so sure, do that here. But for those that can't, you don't have to worry too much about how many sutures it's going to take or the size of the incision. We're just trying to preserve the posterior capsule and the endothelium, which with a lens this dense, you can tell that the chance of a zonular dialysis and retained lens would have been very high, and it's just not worth it. And so in this situation, after I temporarily close, I can remove the cortex. I can still put the same three-piece lens I was expecting to, and the cornea looks better. The posterior capsule's intact. We haven't done a vitrectomy. I have gone through the temporal side port to remove the viscoelastic, and that is the case. So those are my 6 pearls here, and I will stop sharing my screen. And thank you very much for the chance to speak today.
Buenas noches.